Hi everyone, welcome back to my channel. My name is Dr. Kiruka Bridget at OBGYN Talks with Dr. Adazion. I'm a consultant obstetrician gynecologist. I discuss everything about women's health and children's health on my channel. Thank you for subscribing. Please, if you have not subscribed, please do subscribe. Today we'll be talking about a condition on the ovary that is known as polycystic ovarian disease or polycystic ovarian syndrome. Polycystic ovarian syndrome or polycystic ovarian disease is the commonest cause of anovulatory infertility, even from the studies done in Southeast Nigeria. 90% of women that present with anovulatory infertility has polycystic ovarian disease. Initially, it was called a disease because it was thought it to be a disease. However, it has been seen to be a conglomerate of signs and symptoms. And how do we know someone has polycystic ovarian disease? There are three things that are mostly present in someone with polycystic ovarian disease. And these three things, two must be present for you to say that someone has polycystic ovarian disease. And what are they? When there's an ultrasound done on this woman, and you can see up to 12 or more follicles present in one ovary, and these follicles may be arranged peripherally, they just surround that ovary, and they contain cysts. That's where the polycystic name came from. So, and they are up to 2 to 9 millimeters in diameter. It gives you a clue that this woman has polycystic ovary. Or if she has an ovarian volume greater than 10 centimeters cube, it gives you a clue that this woman has polycystic ovary. So this is one of the criteria. Then the second one is that she presents with menstrual symptoms. These menstrual symptoms can be oligomenorrhea. What it means is that she sees her period after 35 days. So her period can stay for 3 months before it comes, can stay for 9 months, can stay for 8 months, or it must be after 35 years. Or that she doesn't even see her period at all. That is amenorrhea. So the woman may come with that she does not see her period with this ultrasound findings, or that she just bleed anytime the uterus wants. That is irregular menstrual bleeding. It's a sign of polycystic ovary. That's the second criteria. Then the third one is that when there is clinical evidence or biochemical, what I mean clinical is what you can see on the body, or biochemical, what the laboratory investigation shows you, presence of androgens, hyperandrogenic levels in the body. What it means that there is presence of male hormones in that person. So if you have presence of androgens, hyperandrogens in that person, is another sign. So when you have, I've mentioned three, when you have two of these three symptoms, it gives you a diagnosis of polycystic ovarian syndrome. Now, the causes of polycystic ovarian syndrome are not known. However, a genetic and environmental factor has been implicated in the cause of polycystic ovarian syndrome, because it's been found that those that are going to develop polycystic ovarian syndrome, every girl child that will develop polycystic ovarian syndrome, do so in utero when they are still in the womb. So some genetic factors has been implicated, because it has been noted that girl child of a woman that has polycystic ovarian syndrome has greater than 50% chance of also developing 50% chances of also developing polycystic ovarian syndrome. So children that are born to polycystic ovarian syndrome women have about 50% chances of developing polycystic ovarian syndrome. Now, other genetic factors have been noted on the chromosomes. Chromosome 11, inactivation of the X chromosome, aneuploidies of the X chromosome. A lot of things has been said concerning the chromosome. It's also been noted that women with polycystic ovarian syndrome tend to have ovarian cancer later. People with polycystic ovarian syndrome are at risk of breast cancer later. So genetic implications has been postulated to be a cause of polycystic ovarian disease. Now, environmental factor, remember I said genetic and environmental factor. The environmental factor include diet. Children that have been exposed to genetically in utero to polycystic ovarian syndrome, or those that are prone to be to have polycystic ovarian disease when they become obese or when they start feeding on fat diet that makes them grow big. It predisposes them to polycystic ovarian syndrome. So diet plays a major important role in getting polycystic ovarian disease. So high fat diet is discouraged, exercise and vegetable and fruits are encouraged. Then secondly is sedentary lifestyle. Someone that is genetically predisposed to polycystic ovarian disease is not advised to stay at a place. It is expected the person becomes active so that it will not start manifesting. Then the third after sedentary lifestyle is age. When someone that is genetically predisposed to having polycystic ovarian disease, we encourage them to start their reproductive cycle as early as possible because the more the person increases in age, the more the severity of the polycystic ovarian disease. So we expect them to get that reproductive cycle before 25 years. So polycystic ovarian disease has both genetic and environmental factor that is postulated to be the cause. So what are the clinical features? Clinical features of polycystic ovarian disease. The patient may present with infertility. That's the commonest cause of presentation because majority of them present with anovulation and thereby having infertility. So when they present to the clinic and investigations are done to not sure that this person has polycystic ovarian disease. Another is menstrual irregularities. They may present with amenorrhea, even when the person is not pregnant. Amenorrhea means that the person is not seeing her menses, then the person is not pregnant and yet is not seeing her menses. So is it, when other things are done, from history, examination, and investigation, we show that this woman has polycystic ovarian disease. It could be oligomenorrhea, just like I've explained, greater than 35 days. Some of them, their menses, the menstrual cycle, comes less than 8 times in a year. So oligomenorrhea or even hypomenorrhea, the volume of menses that comes is very low, or any form of menstrual irregularities. Now, they may present with evidence of hyperandrogenism, just like I say, male hormone. You will start seeing a woman having male pattern of hair distribution. There's presence of beards, there's presence of chest hairs, the legs hairs are so prominent like that of the man. So they have male pattern of hair distribution. So that's another factor. They have acne. They can present with severe acne on their faces. I'll be asking what is happening. Then they may present with obesity. Then ultrasound diagnosis of polycystic ovary. Remember I said more than 12 follicles in one ovary that may be arranged peripherally and they have a diameter of 2 to 9 millimeters. So they are usually about 12 or just an ovarian volume greater than 10 centimeters cube. It gives you a clue that this woman has polycystic ovary. So obesity is also another thing that may present with. This will show you that this woman likely has polycystic ovarian disease. And when you take clinical history, that you ask questions, ask the woman about certain things, then examine the person and do some investigation. When you see these things, it shows that this woman has polycystic ovarian disease. So patients with polycystic ovarian disease can as well also have what we call hyperprolactinemia, though not all of them. But about 50% may have hyperprolactinemia. What it means is that they have galacturia. They present with breast milk discharge even when they are not breastfeeding a baby. So for patients with polycystic ovarian disease that present with breast milk discharge and is found out, management depends on what is found out. How do we manage these people? After we've investigated them and found out that they have polycystic ovarian disease, not just by ultrasound, but by presence of male hormone and also those peripherally arranged follicles on the ovary and polycystic ovary. We can also do some hormonal levels. And part of the hormones we do what we call luteinizing hormone, follicle stimulating hormone. You see that luteinizing hormone, follicle stimulating hormone ratio is greater than 3. So this shows that this woman has polycystic ovarian disease. There's increased estrogen level. There's reduction in sex binding hormone. Sex binding hormones is actually decreased. For someone that has prolactin, that is breast milk discharge, there will be hyperprolactinemia. When these things are found, they are managed. And for a patient that is for an infertility case, how do we manage them? Remember we said that in polycystic ovarian disease, most of them present with increased weight, obesity. Well, it has been found out that for people with obesity, when they lose about at least 6 kg of their weight, they have spontaneous ovulation. Remember, it's an ovulatory. So when the person loses about 6 kg of her weight, she will spontaneously ovulate because the hormones that are stopping ovulation gets decreased. Everything gets corrected, and the person will ovulate and may likely get pregnant. So weight reduction is necessary in these people. Now, if we have done weight reduction and it's not helping, the doctors will go on to artificially induce ovulation using drugs. There are different drugs that can be used to induce ovulation. So it is graded one after the other. It's graded from the lower to the higher. As the person is being managed, if we try this and it's not working, we'll go further to try another one and we'll continue like that. If we have tried medical means using ovulation drugs to cause ovulation and it doesn't happen, we can go surgically. There's what we call wedge resection, though it's outdated, but some clinics still practice it. When you do that wedge resection, they have spontaneous ovulation, is outdated. Now there's what we call laparoscopic ovarian drilling. This helps ovulation to happen. So these are the ways to help the person to have ovulation so that she can get pregnant. Now, if all these things have failed, we can go on to do in vitro fertilization by doing assisted reproductive technology. So the person's egg is gotten, or a donor egg, and a sperm is gotten and fertilized. The egg and the sperm are fertilized and transferred back to the person so that the person can carry pregnancy. Polycystic ovary can cause disease. If there are other symptoms like disturbing the woman, just like I said before, because of the presence of male hormone, they may be having beards, and they will having male pattern of hair distribution. These beards can be removed by plucking, can be removed by bleaching, can be removed by shaving, or can be removed by laser. Anything that will just remove it is done. Then for menstrual irregularities, there are some drugs, some hormonal drugs we give the person so that the person can have a normal menses and still also live a normal life. But for the scope of this discussion, we're talking about infertility, and these things I've discussed are the things we do for patients that have polycystic ovary. For someone that is having breast milk discharge when she's not breastfeeding, there's a drug we'll give to reduce that breast milk discharge, and when that breast milk discharge is stopped, the person goes on to have spontaneous ovulation and can have her pregnancy and carry her baby. Thank you for watching to this point. Please, if you have not subscribed, subscribe to my YouTube channel, follow me on Facebook page or at OBGYN Talks with Dr. Adazion. Look for me on Instagram at OBGYN Talks with Dr. Adazion. I'm also on TikTok at OBGYN Talks with Dr. Adazion. Thank you for watching. See you again for another enriching topic. Thank you.